Dr. Fernando Angarita brings hope and new solutions to the toughest breast cancer cases. Throughout his medical career, he has seen surgery change, treatment options grow, and care become much more personal. From Houston to Colombia, every patient matters, insured or not. During this conversation, you'll hear about advances in treatment, the power of asking the right questions, and why your care should fit you. Subscribe to Let's Talk About Your Breast on your favorite podcast platform or go to therose.org and support our mission. Let's Talk About Your Breast, a different kind of podcast presented to you by The Rose, a breast center of excellence and a Texas treasure. You're going to hear frank discussions about tough topics, and you're going to learn why knowing about your breast could save your life. Dr. Angarita, thank you so much for being with us today. It's such a pleasure to have you here because you take care of a lot of our patients.
Thank you for having me. Yes, I mean, I think the Rose is a great source of patients with imaging abnormalities that get screening through your programs, and we certainly get a lot of your patients into our practice.
I didn't realize that you had that many, and these are our uninsured patients primarily.
Primarily, and also the insured patients. I mean, I think the quality of the Rose speaks for itself, so I think patients seek it out, and also for the uninsured population, it's also a great starting point for the workup of their diseases.
Yeah. All right. Now, I was looking at your CV. You came from Colombia to Canada to New York to Texas. Now, how the heck did that happen?
Life took me there. I mean, I did medical school in Colombia. I always wanted to do my training somewhere where there was high volume, where surgeons did research. That's something that maybe isn't as common in Colombia. And during my internship, I was fortunate to do a couple of months of training in Toronto. Fell in love with the program. There were surgeon scientists, and I thought that was a great place to further my studies. So did graduate studies there, primarily in oncolytic virotherapy, which is kind of a newer thing that's maybe been adopted in melanoma, so to speak, and maybe at some point it'll come into the breast world, using viruses that target breast or cancer cells, kind of like chemotherapy, but have potentially less toxic effects. So did that.
All right, now what is that again? Tell me that again.
So it's a genetically modified viruses that can target cancer cells specifically and avoid the non-cancerous cells, similarly to what chemotherapy does, but potentially with less side effects. And so
already being used.
It's been in clinical trials and it's made its way into melanoma. Because the way of delivery for melanoma, which is a skin cancer, is much easier than if it's deep inside the body. Right. And there are some studies that are being developed for patients with breast cancer, among others. And so that was the area of focus of my graduate studies. I then did my general surgery training there at the University of Toronto, which is the largest training program in Canada. It's a great place to have experience with different types of diseases, surgical diseases, and certainly fell in love with the world of surgical oncology and then breast surgical oncology. And then for that reason, I pursued a fellowship in breast surgical oncology at Roswell Park, which is a very large cancer center in the state of New York. And then eventually made my way here when I got a job in Houston.
Okay, so that was it? You just got a job here?
I looked around. I was open to just, I wanted an academic position to be somewhere with high volume, work in a group with a large volume of other cancer specialists so that, when you're working in a multidisciplinary setting with other specialists, that gives better results for patients ultimately and allows for discussion and management of very complex diseases. So I wanted to be part of that. And I looked around where opportunities were. And Houston Methodist had an opportunity, learned about it. I liked the hospital.
Yeah, Houston Methodist has been a great, great partner of the Rose for many years, many, many years. So did you always want to be a doctor?
I wanted to be an optometrist first, probably because that was my first experience with medicine. I wasn't really a sick child, but I would always go to the optometrist. And so that was kind of my gateway into healthcare.
Oh, I can't see you in a dark room all the time. No.
And and then I think biology in high school, and I thought maybe medicine just had more options, and I decided for medicine.
But you didn't have family members that were physicians?
No.
No?
Nobody in healthcare in my family.
So in Colombia, what did your family do?
My mom was stay at home, and then my dad worked in hotel administration. So nothing related to healthcare.
Nothing.
No.
That is so interesting. When you talked about becoming a surgeon and then finding your way to breast cancer, what was it about breast cancer that appealed to you?
I think it was, first I had a great experience in medical school. The first person or the first surgeon that I ever met, kind of as a naive medical student, was actually a breast surgeon. So it was a very positive experience, and just kind of seeing the relationship that a surgeon can build with patients that are going through breast cancer. I like the longevity of that. The great thing of nowadays a woman and even men being diagnosed with breast cancer is that the majority will outlive this disease and move on from it, so to speak. And so those positive outcomes mean that you can build a long-term relationship and see these patients through the difficulty of the surgical treatment and the active treatment, so to speak. But then in the long term, these patients are in potentially no treatment, and they're just in surveillance, or they're in some form of long-term treatment with minimal side effects. So I like being part of that and seeing that you could take a role in their care in that. I also like the fact that there's a lot of data, a lot of research in breast cancer. So we are fortunate to be in a field of study where there are hundreds of thousands of studies happening constantly, and so it's an evolving field, which means we are pushing that goalpost. We're getting patients farther beyond and getting them better results, potentially with less side effects, less aggressive treatment. And so it's something that is nice to be part of. There's always something new to learn from. Also, the surgeries are something that I enjoy. I can do a surgery for a patient, remove the tumor, get them a cosmetically pleasing result in a way that hopefully can not affect their body image. And so, being part of that is quite helpful.
So have you seen surgery change much since you've been in it?
I've been in practice now for approximately 4 years. I was a medical student, so I got to see some of that in the earlier phases. I would say the thing that's changed dramatically is probably the management of the axilla. So breast cancer, if it's going to go somewhere, majority of the times it's the lymph nodes in the axilla and the armpit. Previously, if you had a breast cancer, you would get what's called an axillary dissection, where all the lymph nodes are stripped.
Right.
Super high rate of lymphedema, chronic arm swelling, so anywhere from 30 to 40%. And we now know that surgery is not necessary for everyone, primarily because it's not going to improve survival, it's not going to improve recurrence, it's going to give that risk of lymphedema no matter what the results are. Right. But our chemotherapy and our radiation and our detection is getting better and better. So that surgery now is now being limited to patients with aggressive disease that presents itself in a later stage. But for the patients that have early stage breast cancer, where it's contained, smaller, we don't have to start with that. If we have to scale up to that for the rare patient, so be it. But for the majority of patients, we are doing less and less surgery, and that's where sentinel lymph node biopsy, where you sample a few of them, has become mainstay. Right. We've also been able now to use that for patients that present with advanced disease in the axilla that resolves on chemotherapy. We used to do axillary dissection for all those patients. Oh, really? Nowadays, if they improve during chemotherapy, you can just sample a few.
Yeah.
So that's changed dramatically. And then also for patients with very small non-aggressive tumors, we can even omit that sentinel lymph node biopsy because it won't really affect their disease management.
And that was always one of the real disheartening side effects. And remember, I'm a lot older than you, and I've been doing this for 40 years, but I can remember the Halsted surgery. So when you think about the progression and how much surgery has changed, it is just amazing.
That's quite true. And I mean, again, with screening being such an important cornerstone of management, it allows us to detect things much earlier, and it makes for the treatments not having to be so aggressive or so morbid.
Do most of your patients have reconstruction of some sort?
Not the majority. Not every woman wants reconstruction. It's a very personal thing. That is something that I've experienced with patients of all
But
types.
that's important for us to hear. Because it is a personal thing. And how do you even approach it, or how do they talk to you about it?
I like to approach it because I think it's important for patients to know what's out there. Nowadays with Google, et cetera, friends, my doctor didn't recommend this, they didn't talk about this. So I like to present the patient with everything, even if it's something that they have not thought of or they've flat out said, I don't want. Sometimes they just need to hear it so that they understand, the availability of it. So for reconstruction, I always bring it up. Most of the times, if it's a small tumor, something well localized, something that if you excise it through a lumpectomy and the cosmetic result won't change that much, most patients do not want reconstruction. It's additional surgery, more recovery. Occasionally, I will have a few patients that have a very small tumor and want to do a bilateral with reconstruction, even though the data supports that it's not going to improve survival. For them, it's important. And so as long as they understand the pros and cons of that, I will support them in their decision. And then there's the patients that present with larger tumors that with a lumpectomy, probably the result is not ideal. And those are the ones that if they're interested, we can have them see a plastic surgeon and we can develop a safe surgical plan for them to have reconstruction immediately, which means on the same day of the mastectomy, remove the breast and the tumor and reconstruct it. And on some occasions, we might also discuss the option of a delayed reconstruction, which is they'll proceed just with the mastectomy, finish up all their cancer treatments, and then half a year from all the treatments ending, they can proceed with that reconstruction. That generally isn't something that we do for all patients, but sometimes if the patient has medical issues that need to be sorted out, that need to be improved, or they're not ready just yet for reconstruction, they want to take things at their own pace, it's a safe thing also to do it in a delayed fashion.
So since you do care for so many of the Roses patients, what do you see that's a little different in our uninsured?
The main thing is a lack of screening, unfortunately. Having no insurance means that there is a huge financial burden for screening, and so they have to seek it out by their own means. And imaging is very expensive, and if something is found, a biopsy and so forth becomes even more of a financial burden. Most of these patients are, working one or two jobs. They have large family responsibilities, and so there's that sense of, I can't get sick, I can't take time off work, and so they're focused on the other people in their family and not themselves, and so that can lead to tumors being presented at a much advanced stage. And so larger tumors, tumors that have maybe now gone to the lymph nodes, so more aggressive treatment is necessary.
Pathology is different. I mean, the whole...
Pathology is a little bit different, yes.
Yeah. We hear that a lot, and I know it has to do with their screening history, but some of it doesn't even make sense. I mean, it's...
Sometimes we see some interesting cases, or they've had treatment elsewhere quite some time ago, and so we...
And now it's cleanup time. Yeah. So do patients actually talk to you about that personal side?
Yes, we talk about their personal life, it's something that I'll dive into to understand, one, what their goals are in terms of treatment, what their priorities are. These patients, for example, have multiple jobs or they have children to take care of, so it's coming to a common ground of, it's time to take care of you. Your family is important. My priority is you as the patient. So we have to get you the appropriate care in a timely fashion so that you can be around to continue doing what you love.
Do you see them feeling empowered because you talk to them in such a candid and personal way?
I think so. I think it helps build a relationship with patients, and it helps make them feel comfortable. Breast cancer is a very scary thing. A lot of people come with preconceived ideas, which come from maybe the history of a grandmother who had breast cancer 30 years ago, who had, a Halsted mastectomy, and it's nowhere near what they're needing. So there's a lot of education that has to happen, and it's very complicated. There's a lot of visits, a lot of testing, a lot of people other than me. We have to get them seeing other specialists. But that conversation is very important to start, educating them and giving them that empowerment that ultimately they are making the choice. They've made the choice to come forth, do the imaging, get the biopsy, seek care, and the rest of it is also in their power. So it's just providing them that support and that space for them to feel comfortable.
We hear so many times from our patients, it was hard to talk to the doctor. It was hard to ask these questions. And many times they don't even know what questions to ask. I mean, who does, really?
Yeah.
Now, you're not the first doctor they see, are you? Are you
It
close
depends.
to it?
I'm probably not the first one when it comes to screening, because unless they're doing high-risk screening, which I provide for patients, with genetic mutations or that are higher risk than the average population, most of the times they're being seen by their gynecologist, their family doctor, their internist. So usually that's the point of contact after the biopsy, and that's where they get that call.
Right.
But I do see patients once in a while that I am the one telling them that they have breast cancer. What I like to do in my practice is have more than one visit. You can't really establish everything and get that level of detail and understanding for the patient in a single visit in 30 minutes.
That's true.
Sometimes patients have to hear it a few times, hear it a few times from a different people, from different angle. Maybe the way I explain it is has a different viewpoint than when a medical oncologist explains it, but I think it's just an education process throughout the whole diagnosis and management treatment.
And you include family?
We always include family if the patient wants, family and friends. Some patients want to be alone. That's fine.
That's true, yeah.
Some patients want to involve many family members. So, it's very personal to whatever the patient wants.
Right. Well, that is encouraging. One of the things we really work toward here at the Rose is to make sure that uninsured woman has the same experience as an insured woman. We may be finding it at different stages, different times, but we don't want her to feel any less than because she doesn't have insurance. So I think that's important that you make it very personal.
Exactly. And I think also, regardless of age, race, sexuality, I think that's what I do is just making sure that every patient is treated exactly the same. Every patient's a priority. I think my office staff always makes fun of me because I want everything done ASAP. And so my counter argument is, well, if it was you would want it done ASAP as well. So, I want patients getting their treatment, and getting the workup and us collecting the information that they need in a quick manner, in a efficient manner, so that the ball can start rolling and, we can start answering questions and organizing the care that they need.
Right. Do you have a favorite type of patient?
Oh, that's a good question. I'll probably have to say no, politely no. I mean, it's great to have a patient who's engaged, who asks questions. I think a patient who comes informed but open-minded to hearing me out. I mean, obviously, I'm coming to them or they're coming to me and we're having a conversation in an open-minded fashion. So I think, when we work in a collaborative manner, because that's really what the doctor-patient relationship is that we're in this together. I think that's the best situation. It really makes their experience much better coming with that approach.
And I want to go back to what you said at the very beginning when I asked you that was I like a patient who asks questions. Even our radiologists say it's so much easier when the questions are being asked and then I know where that patient is. I can kind of test. I can make some decisions then about how we go and that kind of thing. But that is important.
Yeah, it's important to ask questions. I try to be very comprehensive and organized so that even though I haven't seen every combination of every type of patient on the planet, I think I know for the most part what patients are worried about, what their priorities are. Obviously, every patient's very individual. So I think generally by the time I'm done talking to the patient, I've already answered the majority of their questions without them being asked. And then once in a while, there's random little questions and things like that. But I do like when patients come with questions because the moment they leave, that's when everything I've said positive and supportive to help them, all those doubts and fear goes away. Right. Actually, that fear comes the moment they leave because I'm not there to answer questions and they start Googling or wondering. So it's very important that they leave well-informed. And again, as I said, I like to have more of a longitudinal conversation with the patient because it's very difficult to have someone understand all the complexity of their disease and the care that's coming their way.
Do you encourage them between visits to write them down, or?
Yeah, writing them down is really helpful. Messaging us, just asking them at any time. I mean, I think
really?
That's 2025. I think it's really good with the hospital system getting messages in. Yeah. But most of the time, I think we have a great conversation in clinic.
I just want to keep emphasizing that because so many women still, have that fear of, well, the doctor knows best, and I'm going to do what the doctor says. Whether they, we believe that recovery depends on that relationship with the doctor and how much you trust them. Exactly.
I mean, trust is very important. I mean, I think you have to feel comfortable with your doctor, especially with your surgeon. And
how do you fire a doctor? Have you ever been fired?
Not that I know of. Maybe they didn't return to clinic. I think, if there's a relationship or there's a strain in the relationship, the patient might seek care elsewhere.
And you would encourage that if they wanted a second opinion.
A third opinion. I always tell patients, you need to feel comfortable with what I'm explaining, what the other doctors are explaining. You are fortunate to live in Houston where you have many centers of excellence. If you are in a small town, it's difficult, but you are fortunate to be here and to seek care elsewhere. And I certainly encourage, a second opinion or a third opinion, whatever it may be, so that they feel comfortable with what they're going through. At the end of the day, it's about the patient getting the care that they need, but that they feel once they're going into the operating room that they are confident in what's happening to them.
Right. So one of your listed specialties is caring for the older woman. Tell me first, why does that interest you? Why did you get interested in that part of it?
Yeah, so it came from research. So in residency, as I was becoming more and more interested in breast surgical oncology, I had done research, basic science research, so in the lab and so forth, but I wanted to transition into clinical research, and so I found that area of breast oncology of interest. It's a special population within the breast cancer patient group that over the years was becoming more and more of an interest in terms of research. Most of the clinical trials, most of the data and studies focus on the younger patient population, patients who are 50 and 60. But breast cancer, the risk actually goes up with age. So once you hit 70, most patients think, well, I'm out of the woods, I won't get cancer. And actually that risk curve keeps going up into your 80s, into your 90s. So it's important to understand why that's happening, understand what are the differences in how it presents, how to manage it in an appropriate manner, because it's a very particular subgroup of patients with breast cancer. And so my interest became in understanding that, doing research and seeing what their surgical outcomes are. Where can you push that goalpost and make them or give them opportunities where they need them? Where can you scale back and not be so aggressive in treatment?
Help me understand a little bit. How is that different from the 50, 60-year-old?
So the patients who are older, they're in a separate time frame in their life. They're retired, the majority of them. And so these are generalizations. Obviously, there are women that in their 70s that are not retired. There are women who are starting to have competing risks, meaning other diseases like diabetes, heart issues coming up. And so their focus is on that. Some of them, are quite frail. They're living alone. They don't have any children. So there's a very interesting and very particular combination of patient factors that are not so apparent or maybe so present that you would see in a 40-year-old or a 60-year-old. So those are things that you have to factor in when that patient comes in with a breast cancer mass. You get an older lady who's in a nursing home that the care attendant noticed a lump and it's been there for 4 months, right? 5 months. You have patients who maybe have had cancer in their past 20, 30 years ago, and they come back again with another cancer, same breast or the other breast. So it's a very particular patient group that deserves attention, requires a very particular assessment to get them the appropriate care that they need.
That is so true. So many do not have a mate, do not have that person at home to help with things, and it would make it a very difficult and vulnerable time for that patient.
It's a very vulnerable population, resilient population, but there are aspects in their personal history that we have to take into consideration.
Are women as concerned about image as they've always been, or do you think we have changed any in that way?
I think image is always important for most patients when you're talking about the breast, but there are a considerable number of women who don't care. I think as a surgeon, I always tell my patient, I care that I want to give you the smallest scar. I want to take out the least amount of tissue. Right. I want to factor in, the relationship or the ratio of the breast to the tumor size and see what would potentially be the amount that needs, plus all the changes that are going to happen after the surgery, after the radiation, et cetera. And could you feel comfortable like that? But if you're in doubt, maybe we explore reconstruction. Maybe we explore oncoplastic surgery, where the plastic surgeon rearranges some of the tissue to make a smaller breast that looks more cosmetically pleasing. But let's explore it. Let's talk about it and think about it, because I know you're stressed about what's happening right now, but I'm seeing you in the long term, and I don't know, or we don't know yet, how are you going to feel 3 years from now, 5 years from now. So it's, again, when I was saying that longitudinal conversation, that happens over time. And I always tell patients, we can always do more surgery, right? If you do a mastectomy with reconstruction and you regret it, that's a difficult thing. But we can always do more surgery. We can always do reconstruction. There's other things that we can add to the mix. But essentially, I think women, for the most part, want to look down when they're seeing themselves in the morning and see nothing that reminds them of that cancer, right? And so that those are all conversation points that we have, when talking about surgery. And that is so true.
I mean, I've had breast cancer survivors who've said, every time I look in the mirror, I know I'm a survivor. I remember, because some of the surgeries, especially in the past, were pretty drastic and not always concerned with that cosmetic look. So it's so encouraging.
And the data shows that we have to, the cosmetic aspect, body image is very important for women's psychosocial well-being, for their sexual well-being. So we there's a lot of qualitative data supporting that. And so that's where that conversation about where the incision is, how much tissue are you going to take out, what else could it look like, et cetera, that needs to be discussed as you're consenting them for surgery. That's as important as what's the risk of the infection, what's the risk of pain.
Right. That is so true. Yeah. And those are the questions most women would be a little uncomfortable asking, or not even know that those are possibilities.
Exactly.
Yeah. So if you had a closing message for our listeners, what would it be when it comes to breast cancer, deciding on a surgeon, deciding on what type of surgery?
I think just knowing that breast cancer, although it's complicated and scary, there's a lot of great advancements in care, surgically and non-surgically, that allow the vast majority of women to have or survive from this disease. Sometimes it requires very aggressive treatments. Sometimes they're not as aggressive, but breast cancer is very personalized in 2025, and it will continue to be in the future.
Right.
So the care that you are being offered and the recommendations are based off of the vast majority of these great studies that have been done in thousands of women. So that's something that women nowadays are very fortunate that although you are being diagnosed with this, your care is very personalized. And that's what makes it complicated, but makes it the exact right thing that you need. And I think in terms of finding a surgeon or a plastic surgeon, I think it's very important to go towards centers of excellence, centers where there's a high volume of breast cancer care. So, for example, where I work at Houston Methodist, we have fellowship-trained breast surgeons and breast radiologists, as you guys have here at the Rose. So it's always looking for high volume because that's where you have excellent outcomes. And I think also, very importantly, feeling comfortable with your surgeon, feeling comfortable to ask questions, because it's a longitudinal relationship that you ultimately have with that person.
Well, that is great advice and a great message. Thank you so much for taking care of so many of our patients, and particularly for caring about our uninsured. I know it takes a different kind of caring many times when you're dealing with someone who doesn't have all the things that a lot of people do and is having to make tough decisions. So thank you for that.
You're welcome.
Thank you for joining us today on Let's Talk About Your Breasts. This podcast is produced by Speak Podcasting and brought to you by The Rose. Visit therose.org to learn more about our organization. Subscribe to our podcast, share episodes with friends, and join the conversation on social media using hashtag Let's Talk About Your Breasts. We welcome your feedback and suggestions. Consider supporting The Rose. Your gift can make the difference to a person in need. And remember, self-care is not selfish. It's essential.